Rachael Fischer is a speech pathologist. She runs her own speech pathology. She also lends her time to our newly diagnosed seminars. And more importantly, she is one of our support group leaders for our Belrose Young Onset group. So welcome, Rachael. Thank you so much for lending your time today to speak to us all things Parkinson's and speech. And we'll hand over to you.
Wonderful. Thank you, Stacey. Thank you for the honour, and I do say the honour, I always say it to the early diagnosed too, of being here today. I mentioned to Meryl and Stacey, this is different for me. I usually am used to having questions kind of thrown at me as we present. So please feel free to pop some questions into the chat box as they come up. I have tried to allow some time at the end of the presentation to take your questions and really be able to give you a bit more personalised information. I apologise for my nasally voice. I'm on week 3 of a sinus infection, as we've all been sick this winter, so I'll do my best to get through. But yeah, so today, before I share some slides, I wanted to really give an overview into the role of speech pathology in Parkinson's disease. We're going to talk quite specifically about some programs for voice and speech, but also cover areas which are lesser known, some of those non-motor symptoms that you can potentially present with Parkinson's disease that speech pathologists can help you with. So without further ado, I'm going to try and share my screen with a bit of a presentation. Bear with me while I do that. And of course, that toolbar goes right where I don't want it to go. There we go. So as Stacey says, so a little bit about who I am. I've been working directly with Parkinson's disease for 12 years. I guess it's always been an area of passion and interest for me. It's a huge part of my primary caseload. I'm really honoured to have a team who work with me here, and we're all trained and really passionate about working with Parkinson's disease. Come on, slide. Sorry, guys, 1 second. I knew this would happen. Why won't it move? Oh. Any suggestion? There you go. It's just slow. Okay. So some of you may have had some of your own experience working with speech pathologists, and we're much more than stutters and lisps, especially working with the PD and adult population. We covered typically anything from the neck up. So swallowing, speech clarity and articulation, voice, and that includes the softness, the pitch of your voice. We're going to cover that in a lot more detail. Language, so how you find your words, how you understand words, and stuttering. So these are the main domains that as speech pathologists we're all trained in when we come out of university, and we then tailor our knowledge based on our expertise and our caseload. I'm so sorry, guys. I'm just trying to figure out why it's taking so long to move between slides, and I think it might just be because of the overload on the there we go. So I think, as we all already know by now, every presentation of Parkinson's disease is just so very, very different. And in my experience anyway, anyone who comes to my office or when I visit them at home, and I've worked with lots of individuals with Parkinson's disease, very rarely do they ever present exactly the same. And I know that might be, I guess, maybe it's reassuring, maybe it's not, but I want to always preface my presentations with that, because what I'm going to mention may or may not occur for you, but the idea is really just to provide the information so you can monitor the symptoms. So I guess that leads me into what is the purpose of today, and I guess it's about providing information so you can help identify, that sounds kind of true to me, that sounds about right, I'm experiencing that, or I'm not experiencing that, to get into some early therapy, and I'm going to talk about the importance of that in a minute, so we can help maintain and improve your function. We're not saying we can fix or find a cure for Parkinson's disease. Goodness, I wish that we could, but we definitely know that with the right therapy, with the right therapist and the right intensity, we can improve function and help improve your communication and swallowing abilities. And then monitor, and we go through a cycle and back to providing information and identifying concerns as we go throughout the progression of the disease. I put this in here. I stumbled across this analogy recently during a podcast I was listening to. I'm a big podcaster and follow all things Parkinson's and speech through podcasting. And I really liked this analogy of the dental model, right? So people often say, when should I see a speech pathologist? And I think, okay, well, this was really cool. So it's kind of like a dentist, right? We don't just go to the dentist, hopefully, when we need a root canal, when things kind of escalate and suddenly we need a root canal. We go to the dentist regularly to have our teeth cleaned and have a checkup so that we can avoid having root canals or avoid crisis mode. And I thought that really applies really nicely to what the evidence is showing about speech pathology, which is we want to see you early, even if it's to say, you're good, see you in 3 months' time. Keep an eye out for these things. See you later. We really want to be checking in with you on a regular basis. And the thing I like about this is it really also allows you to develop a relationship with your clinician. And the team at Parkinsons New South Wales and I hammer on about this quite a lot, about finding the right people for your team and finding clinicians who you really trust. And so if you're checking in with someone early, you can go, oh, are they the right fit for me? Are they not? Instead of having to reach out to someone in a crisis mode that maybe doesn't have the right experience or you don't have that lovely rapport with and that mutual respect. So here are some things, I guess, that Parkinson's disease quintessentially can affect in regards to our communication. And by and large, the biggest one is voice. So many people, and I read a research paper only last week that said this is one of the very, very, very first signs and symptoms of Parkinson's disease that often people attribute or notice even prior to their diagnosis. And it's not until they get their diagnosis that they have that light bulb moment. Oh yeah, that's what that could have been. So voice strength, range and quality. Speech clarity is kind of moving up the system and talking about how articulate we are and making sure that the speech is not slurred. For some people, it can be quite quick in rate. So speaking quickly and in bursts of speech is quite a characteristic of Parkinson's disease. Swallowing function, so changes to the way that you eat and drink and the safety around that. Again, these are all muscles that are impacted by the hypokinetic movements. Language skills and cognition, and most impactfully cognition, a lot of research is showing changes in divided attention, so the ability to multitask, and that being quite a primary symptom for Parkinson's disease. There's a lot of emerging literature in that area. Again, just to come back to the thing that we hammer on about, but finding the right fit. And again, we can use all kind of medical analogies for this. We don't go to an orthopedic surgeon for a cough. We don't go to a pediatrician for a broken leg. Not all speech pathologists are passionate about working in Parkinson's disease. So for example, at our practice, we only see adults. So going and finding a speech pathologist, you need to be asking the questions. And I'm not saying just my practice, there's lots of wonderful practices out there in Sydney. And Parkinson's New South Wales can provide that information. And there are practices also across the states that work specifically with Parkinson's disease. But these are some of the questions you want to be asking before you lock in is, do you have experience and passion working with Parkinson's disease? Are you certified in some of the voice programs, which I'm going to discuss with you? So you'll get an idea of what those voice programs are. Are you committed to ongoing professional development and research, and what does that look like for you? Then when you meet with them, can you establish a mutual respect and trust, and do you have rapport and a relationship? So just some things to consider, and you're welcome. I think these slides will be available to refer back to if and when you're considering reaching out to a speech pathologist. And I dare say these kind of guidelines can apply to any allied health or health professional. Okay, so just for this is probably the most confronting slide in the presentation, and I've put some references below so you can see where the statistics were gathered from. And this is why I guess speech is now one of the 4 pillars of Parkinson's management, is because of the sheer magnitude of how many people it can affect. 90% of individuals will likely experience some speech or voice difficulties. So again, that's about the strength of the voice and the articulation of the speech. And 80% will experience symptoms of dysphagia. What this data doesn't account for is how severe that is. This is just anyone. So some people can experience the mildest of symptoms, and some people, the more severe side, are still included in this data. But as you can see, it is very prevalent amongst the population. Okay, a quick opportunity if anyone wants to pop anything in the chat box about that introduction, I'll give you just a couple of seconds. I can always circle back to it at the end. Before I move on to talking about what an assessment looks like with a speech pathologist, because sometimes having the knowledge of what it's going to look like can help people feel comfortable reaching out to a clinician. I think sometimes that fear of the unknown of like, oh, what are they going to do to me? And what can I expect can be a little off-putting. So I've tried to break down some of the stigma here and have a little look at what it may, how it might be experienced, I guess, for you. Okay. So something that we may ask you to do, so if someone calls me up and we have a nice chat on the phone about what's happening for them and while we're doing intake, if your main concern is around your voice strength or something to do with your vocal quality, I may ask you, or speech pathologists may ask you to consider going and seeing an ear, nose and throat surgeon. We don't always. Sometimes we're happy to see you first and work out if it's necessary. This is considered gold standard care. If we're going to do any work on the voice, we want to make sure that what we're doing isn't counteracting anything else happening. So our voice is a really delicate instrument, and sometimes we have things like polyps or nodules that have occurred over time, not related to Parkinson's disease, just something that has happened across the lifetime. But the therapy we do for Parkinson's and voice includes a lot of force on the vocal folds because we're trying to get the vocal folds to come together. I'm going to talk about that in a minute. And if there's any of those other little pathologies on the voice, we want to know about them so we're not causing more harm than good. As I said, this is gold standard. Not every speech pathologist will recommend it. Sometimes it's not appropriate, but don't be off-put and think, why have they asked me to do that? It's just because we want to rule out that we're not going to contraindicate anything else that's happening. So what does an assessment look like? We at Connected Speech Pathology like to keep our assessments relaxed and engaged whilst also collecting the information that we need. There's no fancy tests or poking and prodding. A lot of it's done through conversation and through little activities we're doing with the voice. But the first and most important thing we do is we take a really comprehensive history. And this will include questions about everything. Some things that you may not even think, why is that related to speech pathology? It might be about your medication, or have you seen a dietitian? How frequently do you see a neurologist? But these are all things that help us paint a picture about how you're performing and how you're going with your Parkinson's, and also because medications can interact with on and off periods which affect voice and communication and swallowing. We might ask you some screening questions about what you're finding difficult. We collect some data. We get people to perform some of these. If any of you have seen speech pathologists before, you'll be familiar that we get you to perform activities with your voice like gliding pitch, holding a sound. We're trying to check how strong your voice is, how strong the decibel level is. If swallowing's a concern, we might have afternoon tea together so we can check what's happening. And then at the end of an assessment session, we sit down and we go, okay, with all this information we have, what do you want to work on? And what's important to you? And that's a really important starting point during the assessment. And that then determines the plan moving forward. So sometimes it's like, well, you're doing really well. We'll see you in 3 months. And sometimes the answer is, your voice is causing you a lot of distress. Let's do a really intensive block of therapy for 3 months or so, and then you can be on your way with a maintenance program. I'm going to cover that again in a second. But all these things should be discussed during an assessment. Okay. So therapy, what does the therapy actually look like? And I think this is what people often are really interested about, is what can we do and how can we help? And there are so many different programs and approaches to Parkinson's disease. And fortunately, a lot of them are evidence-based now with some strong literature behind them. And I'm going to discuss that as we go. So on a very basic level, therapy for speech pathology in Parkinson's can be broken down into these 3 approaches. So the first one is speaker orientated. So this is when we work directly with you on your speech, on your voice, on your swallowing. It's about the programs and the intervention targets. We're building strength and we're building, we're working on the impairment itself. The second is communication orientated, which is about working with maybe your partner or your children or your workplace, if consent's provided, to look at how they can help you and support your communication. It's about training them to support you. This can also involve strategies like modifying your environment so that it's easier to communicate, and really practical approaches. And the third is working on augmentative and alternative communication, which is abbreviated, thank goodness, to AAC. And this is for people who are experiencing really severe difficulties communicating. There's a whole bag of tricks we have as speech pathologists to help remediate that and provide supplements for that, supplemental technology, I should say. And sometimes the therapy is a combination of these three things. It's very rarely just one. When I see clients for even the direct programs, there's an element of communication partner training in there as well, or discussions about how we can alter the environment. But again, just a little bit of overview into what that therapeutic approach might be. Okay, so what does effective therapy look like? And this has been taken from literature, which I haven't included the reference, so I will go back and put that in. But a lot of the therapy for Parkinson's disease works on the principles of motor acquisition. So we want to always set goals that are realistic and that everyone's clear on, so we know what we're working on together. I like my clients to be able to tell me back what they're working on, so we feel like we're doing something together and we're really working towards a common goal. But when we actually get into the therapy itself, we want really high repetition of targets. So if you see a speech pathologist, don't be put off if they make you do the same sound or the same thing 20 times in a session. We're trying to, a bit like going to the physio, you don't work on your biceps by doing one bicep curl. You know, unfortunately, you have to kind of do sets of 20 bicep curls. And I like to use that analogy a lot when talking about speech therapy. This is kind of physio for your voice or for your speech or for your swallow. We like the activities to be functional, so we're not just doing random targets. The words we're targeting or things we're doing with our voice is about helping you improve your engagement in your daily life. And we get you to do carryover activities. So now take this and go call your friend. Or we want you to do these exercises the next time you're giving a speech at work or when you're reading a book to your grandchildren. And so we give you suggestions about how you take that into the real world, which is often the most difficult step. Apologies. Okay, so as I mentioned at the outset, this is the biggest area that we tend to cover, and it's the area where the most research has been done, and there's some really good evidence-based programs to work on voice. Some of you might even have some familiarity with them already. So, what can we see with voice? Often we see changes to the quality, so it can sound breathy. Think Marilyn Monroe, really breathy quality voice. Or it could sound hoarse, sorry, busy office today. Or it could sound hoarse where it feels strained and tight. So that's the quality changes. Most frequently, it's the changes to volume. So it sounds soft. I have trouble pushing my voice. And there's also with that a bit of a reduced awareness. So it's very common that someone's wife, husband, friend notices the person with Parkinson's voice gets softer before the person with Parkinson's. And there's a bit of research going into that at the moment about why that is, and it's something to do with a sensory feedback loop. It's emerging. And changes to pitch. So it's quite common as well that we experience quite a flat or monotone voice with Parkinson's disease. The following programs I'm going to talk about are targeting all of these aspects, in particular the volume. Okay, what's physically causing these changes? So one, as I mentioned, it's a sensory change. Sometimes it's the fact that we're not able to quite recognise that there is a weakness in our voice or that the person is speaking softly. The second is a physiological change, which is sometimes people with Parkinson's experience a bowing in their vocal folds. So if you look at these pictures down here, very crudely, it's kind of if we chopped our head off and we were looking down. And when we produce really lovely, clear, loud speech, our vocal folds come together in a lovely pattern. But if they're physiologically bowed, They come together in kind of an awkward, suboptimal pattern, and that can be a cause of the vocal softness and changes to quality. And respiratory changes. We know that people with Parkinson's can experience these changes to their vital capacity. And if we don't have a strong set of lungs, it's really hard to project our voice. I always think of the lungs with voice like the power source. So these are kind of driving the power, and then the voice is the instrument. I guess if we use an analogy, I'm not a musician, apologies everybody, but that's kind of my crude explanation of using a music analogy. So what are the programs? And I dare say there's a few of you who are familiar maybe with a couple of these, and I hope I do them justice in explaining them. There's a very long-standing, well-recognised program called the Lee-Silverman Voice Technique, LSVT. And this has been around for a while. The focus of LSVT is think loud. It's kind of similar to PD Warrior. Think big. It's all about moving your muscles, being really, big, loud, pushing. The focus is on that and that alone. The sessions we recommend are usually really structured and highly intensive. So if this program is recommended for you, the best way to do it is 16 one-hour sessions across 4 weeks. Now, that's not always possible, but that's where the evidence supports that it's most effective. It has a maintenance program too. So once you've done the program, there's kind of weekly check-ins with other people. You get linked in with the community. I've got here evidence-based with a star next to it, and this goes for the next program too. And the reason for that is when you look at the evidence for this, it is strong. There's, I guess, suggestions that it works, but a lot of the research done has been funded by LSVT or by Speak Out. So I always bring that up because, it's a little biased. Would I fund a whole research that was going to show it didn't work? So anyway, just keep it in mind. But in terms of anecdotally, we've definitely had clients who have made improvements with both of these programs. So Speak Out has also been around for a while, but it's really having a moment in speech therapy. This is the program I'm trained in, and it's the program my staff are trained in, and it's one that I'm really getting behind at the moment. And I'll explain that in a minute, and it's because of the neurology behind it. So it's very similar in its structure, lots of intensive sessions, I think 12, you can kind of do them across 3 to 4 weeks. It's very structured. There's a maintenance program. Again, when you finish, you get linked in with the community, similar evidence-based. But the focus of this, I'm so sorry, drippy nose. The focus of this is on intention, about speaking intentionally, not just loudly. And my next slide explains why that is quite groundbreaking, I think. Yeah, good. So the neurology behind Speak Out and the focus on being intentional is that when we use an intentional voice, we are using a neurological pathway that is less impacted by dopamine. And we all know how important and the role dopamine plays in Parkinson's disease. When we naturally talk to our family and to our friends, and a little bit like what I'm doing now, I'm not thinking about my talking, I'm just doing it because we've done it since we're 1 year old, right? That process requires more dopamine. And so by overruling that, by using intentional speech, I'm now really projecting my voice. I'm thinking about my talking. We're using that conscious movement. It's really exciting stuff. And it's why we're having great success with therapy for this module and using this program. What it does involve, which is great, is, how do I put this? What it involves is working through a set of systems and eventually increasing the cognitive load. So we start with really simple tasks and a set of warm-up activities. And as you progress through the program, we get you to use your intentional speech while debating a topic or thinking of 5 things that start with a letter B. So we're trying to promote you using your intentional speech with more demands that replicate what you would experience in your everyday life. I'm quite passionate about this program because I've seen the effects of it really strongly. Moving on to speech. And again, I know we'll probably have some questions around the voice at the end. But speech is kind of moving up the system here. So now I'm talking about the movement of your lips, your tongue, your jaw, your palate to shape the sounds. This is producing the sound and this is shaping the sound. Here's a picture. If we kind of cut ourselves down this way now and pulled ourselves apart, a sideway view of all the articulators involved in speech. I did see a stat somewhere that said in a minute of English speaking connected speech, so kind of what I'm doing now, we produce 1,400 different sounds in 1 minute. Think of the coordination that's involved with all these muscles that go into that. And if we have dopamine reducing the movement, the impact that it will have on our speech is quite drastic, or can be quite drastic. So what does that look like? It can look like changes to speed because the articulators are having to move really quickly to produce that speech. Often they are reduced in movement, and as they reduce in movement, the speed picks up. So it looks something like this, hello, my name is Rachel. So my mouth is moving less, but to do that, the speed is having to increase. It also looks like unclear speech. So slurry quality, imprecise sounds. Some people say, I sound a little drunk. I sound a little drunk. And that was one of my clients' goals actually a while ago, is I keep getting, rejected from the pub because I can't get in. They think I'm drunk. And it wasn't. It was just articulation changes at that time. So what do we do for this? Unlike the voice, there's not a lot of set programs for speech, but we like to follow a framework that goes something along this guideline. So we want to we teach our clients to recognize the difference between what they're currently doing and what we want them to do. We hone in on what's the motivation to change. So like I said, for this client, it was getting access to the pub. We want to find the motivation. For some people, it's being able to have and be heard and articulate across a dinner with the family. We set the goals, and then we call it flipping the switch. So then we teach people, we really need to think about, again, using intention, we really need to think about your talking and teach people to use the therapeutic version of speech, which is all about clear speech and intentional speech. Then we teach our clients to evaluate and go, oh, was that a good production of speech? Was it not? Maybe what could we do differently to make it a bit better? And then we add that cognitive load again to replicate what real life situations would feel like and be like. This approach is called kind of mind over motor. And again, I've included a reference. It's really interesting reading. Swallowing. Again, it's something a few people come to me like, I didn't realize the speech pathologists do this. And it has a history from many decades ago where it was kind of handed over from the doctors to us, and we work still quite collaboratively with doctors in this domain to help people eat and drink safely. And this is my area of interest, this is my real passion, as well as Parkinson's disease, but because I often say this at the other presentations, I can't remember the last time I had a social gathering where I didn't eat or drink. Even if it was going for a walk with my friend, it always ends in a coffee. Maybe that's just me, but eating and drinking is crucial to survive, but it's also crucial for our social interaction and our engagement. So we want to support you to do that safely and enjoyably. There's 3 phases to swallowing: the chewing and moving the bolus and fluid around your mouth, oral phase, pharyngeal phase from your chin down to your sternum, which is demonstrated in the picture here where this big gluggy mess can be seen, and the esophageal phase, so once it goes from the esophagus down into the stomach. A speech pathologist can help evaluate the first 2, so the oral phase and the pharyngeal phase. We know that the esophageal phase is really impacted by Parkinson's disease. There's a reduction in that movement to squeeze food down. And so it does interact a little bit with the first 2 phases, because if you get reflux, it can often come back up into the pharyngeal phase. So again, we work really collaboratively with doctors or gastroenterologists if that becomes a problem. What are the signs to look out for? The obvious ones are obviously coughing and choking. So when you're consuming food and fluid, that you're getting increased sensations of choking or coughing repetitively with certain textures. a wet sounding voice, sounding like you're kind of talking underwater or feeling like you're talking underwater, dribbling, it taking a really long time to have your meals, and meals kind of running breakfast into lunch, lunch into dinner, or a meal taking longer than about 40 minutes is a sign that maybe swallowing is a concern. If eating and drinking your dinner wears you out, maybe that's a sign something's going on. If it makes you short of breath or wheezy, if you constantly have food in your mouth, these are the main signs that things are changing with your swallowing function. On that last little box, you'll see sometimes there's no signs that something's wrong and things still end up in our lungs. That's a very small portion of the population. Usually we have one of these symptoms at least alerting us to the fact that there's been changes to the swallow. Why is this so important? I think it's implied, but the reason we want to get our swallowing right is, again, for enjoyment, but also because it can be dangerous. If something enters underneath our epiglottis, through our vocal folds, down into our lungs and settles there, it can cause an aspiration pneumonia, which is uncomfortable at the very least and dangerous at the very worst, and can be deadly as well if left untreated or even treated. So we want to obviously reduce the risk of that happening as much as possible. If a swallowing concern goes unidentified as well, what I do often find is that my clients lose weight and become dehydrated or malnourished. And that's because that understandably is, oh, I don't want to eat and drink. That's hard. You know, it's uncomfortable. And so we end up then with those carry-on impacts to dehydration and nutrition, which again, we know is so important in the management and overall well-being of ourselves and with Parkinson's disease. So how do we treat it? So people always, I have had a few clients say this, I didn't want to come and see a speech therapist because I was worried they were going to put me on a puree diet. And look, modifying the diet, like you can see here on the right-hand side, is something we are able to do and help recommend to make it easier to swallow. But I want to reassure you on the behalf of my profession that we try everything else before we have to start modifying what you eat and drink. Because I've said before, if someone tells me one day that I can't have ice cream or a cheeseburger, I will not be happy. So we also agree how important it is for you guys to eat and drink what you want to have. So the first thing we look at is, how can we compensate? You know, can we put your chin in a different position? Can we modify the spoon you're using to make sure your mouthfuls are less? Do you stop coughing when you use a straw or a certain cup? So we look at compensating for the difficulty. And then we might also try some therapeutic approaches to help build up the strength in the areas that we think are causing the swallowing difficulty. And in the meantime, if absolutely necessary and with your consent and with your collaboration with your speech pathologist, we may look at modifying your food and drinks to keep you safe. But again, reassuring, that's not what we jump to straight away. These are very general swallowing strategies I want everyone to be doing, whether you have Parkinson's disease or not. When you're eating, eat what is recommended, sit up 90 degrees, don't eat your dinner and then go straight to bed. I don't think many people do that, but I think that is really important, especially with Parkinson's disease due to that reflux or that potential for reflux. Reduce distractions. So try to focus and be, here's that word, intentional on what you're doing. Take slow and small mouthfuls, which can be hard if you're a habitually quick eater, and ensure that you're eating and drinking during your on periods as much as possible. So let's not make our off periods any more awful than they have to be. Don't worry about eating and drinking during those times. Try to work your meals around the times of the day where you know you're feeling good. So just very quickly, I haven't covered this in a huge amount, but just a little flag for you to think, oh, okay, this is related to Parkinson's disease and there's someone there that can help me. The lesser known non-motor symptoms of Parkinson's disease. There's still a lot of research going into why our language and our cognition is affected, but we know that the dopamine is produced deep within the brain in the basal ganglia, but the basal ganglia talks to our cortex and talks to the centers of the brain where our language and our cognitive skills are controlled. It's a very basic, you didn't think you're going to get a neurology lesson today. Okay, I'm going to skip past this page. Let's talk about cognition. So cognition are all the tasks that we do during the day. It's often referred to executive function, so planning things, making sure things are organised, attention and the ability to sustain my attention on something or divide my attention between things. That's to do with attention. Ladies, I know this is a sexist comment. We all think we're better than men at multitasking, but unfortunately, the science and neurology says no one's good at multitasking. What multitasking is actually the ability to divide your attention and quickly flip between two things. That's multitasking. And with Parkinson's disease and changes to attention, we know that can reduce. So you might still be able to go between activities, but it takes you longer to switch between them. It's a really big concern that I see clients present with sometimes. And changes to memory. Again, it's a potential that some people experience difficulties with long-term, short-term, or working memory. The biggest thing I see across my desk is more the working memory. So the ability to hold information in the head, work it out, and then spit it out. So think of like a maths problem or working out how to catch public transport. They're more the memory concerns that I'm currently seeing. Okay. Language is quite separate to cognition. They do work interchangeably because everything in the brain is networked together, but language is now talking about how you process words and how you express language. Sorry, guys, I'm going to just pause for a second. So it's about changes to how you express yourself. So some people will report increased word finding difficulties, difficulties planning what they want to say. Some people may experience changes to their understanding. They find it hard to understand or comprehend long text, verbal text, written text. And some people, again, which links in, experience difficulties with reading and writing. That doesn't refer so much to the micrographia. That's more the domain of an occupational therapist. This is more about how I'm constructing my sentences when I'm writing. So this kind of goes back to what I said at the beginning to wrap up the presentation is when do you get help? We want you in, the earlier the better. Think of the dentist. Preventative is better than a cure, so to speak. We wish we had a cure, so let's try to prevent and keep your skills as strong as possible. When you're concerned or a loved one is concerned, and when you just want to have a chat and maybe get some advice about what's going on. Seeing a speech pathologist. So how do I arrange that? You do not need a GP referral. GP referrals can provide, if you're paying privately, an EPC. I'm not too sure if anyone's familiar with those, which give you 5 sessions where you can get a rebate. It doesn't cover the whole cost of a private therapist, but it gives you about $60 back of a session. There are fabulous public system speech pathologists in local hospitals who are experienced working with Parkinson's disease. I encourage all my clients who see me privately to put their name on the public system as well. And they kind of dip in and dip out. They see me and then they might see the public speechy. The waiting list for public speechies are really long, understandably, because their service is free. And they often only provide a short intensive block of therapy. If you're under 65, NDIS, with the right plan, can support the cover of speech therapy. And if you're on a home care package and you have the funding within the home care package, speak to your provider, as speech therapy is often covered under that as well.